All right, well, it's 12 o'clock on my computer, so we'll go ahead and get started. By way of introductions, my name is Brian Ulrich. I work as the director of the Interprofessional Education Office here at Grand Valley State University. I'm excited you could join us for our March Lunch and Learn. The lunch, just as a reminder, the Lunch and Learn series is offered throughout the academic year from September through April. And these events are free and open to students, faculty, staff, and community members. And these events feature speakers who are incorporating elements of interprofessionalism and collaborative practice in different settings, in various healthcare settings. And each session features a very timely topic related to healthcare practice and delivery. And today's topic related to community mental health and COVID-19 is no different. Let me introduce our speakers real quick, and then I'll turn it over to them. Quick reminder too, in terms of questions, please hold questions to the end, and we'll give you a chance at the end if you want to. You have a couple options for questions. If you want to just type something into the chat, that's certainly an option. Or if you want to ask your question live and turn on your mic or camera, you can use the raise hand feature, and I'll call on you to go ahead and turn your mic and camera on at the end, and you can ask your question that way too. So either way's an option, and happy to have some time at the end for questions. So we have two speakers today, both from Pine Rest. Dr. Eric Achtyes is a staff psychiatrist and researcher holding appointments at Pine Rest Christian Mental Health Services, Cherry Street Health, and Network 180, all located in Grand Rapids. Dr. Achtyes' main research interests include improving treatment for patients with schizophrenia and depression, and he also currently serves as president of the Michigan Psychiatric Society, representing patients and physicians across the state of Michigan. Kristen Spykerman's a social worker, and she's the chief clinical officer with extensive expertise in primary and behavioral health care integration. She also has experience with designing, piloting, and implementing primary and behavioral health care integration services for adults and children. And Kristen has a lot of expertise in diverse evidence-based therapies, assessment, and crisis intervention. So with that, I would like to turn it over to our speakers, and I will go ahead and turn my camera and video and mic off until the end, until it's time for questions. So I will turn it over to our speakers.
Well, thank you very much, Brian, for the introduction. My name, as Brian mentioned, is Dr. Eric Achtyes. I'm the Behavioral Health Medical Director at Network 180. And Kristen Spykerman is with us today too. She's the Chief Clinical Officer here. And we work together to oversee the clinical care for those served by Network 180 and its member organizations or partner organizations. So we, in this role, we oversee the public mental health care safety net for about the 655,000 residents of Kent County.
Okay, hello everybody. We're excited to be with you today and to talk about the work we've been doing and how COVID-19 has affected community mental health. So I first just wanted to start out by giving you a little bit of an introduction to Network 180. So Network 180 is the Kent County Community Mental Health Authority. And so our primary service area is Kent County. Every once in a while, we will serve others outside of Kent County, especially if that's for crisis services, but that's really our primary designation. So we're one of 46 community mental healths, or part of that safety net that exists within the state of Michigan. There's mostly Medicaid, it's mostly Medicaid population that we serve, but we also do serve others who may have private insurance or some who are uninsured as well, but primarily we serve those with Medicaid. We do mental health treatment. So for individuals who have serious mental illness, we do substance use disorder treatment, intellectual and developmental disabilities. This is both for kids and for adults. And that includes a wide variety of services for youth with autism. And then services for youth and families. So kids who might have a severe emotional disturbance or as I mentioned, autism, an intellectual developmental disability, infant mental health. So there's a wide variety of services we offer there as well. We don't deliver all of those services ourselves. We partner with about 150 other organizations, provider organizations, including hospital systems, adult foster care homes, residential treatment facilities, crisis residential facilities. So we don't do this alone. We actually serve about 15,000 to 16,000 individuals per year in Kent County through us and our provider organizations. Network 180 itself does about 20% of that direct service, and our providers do the other 80%. Next slide.
So we thought we would get started just by sharing a brief history of COVID-19 in county. And this is really looking back a little over about a year ago to some of the events that were happening. And it's hard to believe, but it was March 1st of last year that the first COVID positive case was identified in Kent County. And by March 6th of this year, so a little over a year later, we had over 49,000 confirmed cases and more than 650 confirmed COVID-19 related deaths. So we've really seen the impact of COVID-19 on our county in the last year. Now, you may all remember it was about this time last year that the governor instituted the first stay-at-home order. So that began on March 13 and went for about 6 weeks until the end of May in 2020, where they limited all gatherings and activities deemed unnecessary to sustain life. And since then, we've had a series of executive orders reopening different parts of the economy, different parts of restaurants and other sorts of places where we would gather. And so we've seen this kind of slow opening of services, but we're going to share a little bit of some information about what was happening with our services during that time when everything kind of immediately halted. One of the changes that accompanied this was the Michigan Department of Health and Human Services revised their place of service requirements, allowing us to deliver a lot more of the services we provide via telehealth. And so they made that telehealth exception retroactive back to March 1 of 2020. And then later on in June, the governor signed legislation mandating that Medicaid and private insurers continue to cover telehealth visits even after that immediate crisis had subsided. So this is just helps you kind of understand the regulatory environment in which we were all working.
So as Dr. Achtyes mentioned, we really needed to transition care quickly. So as the first case was discovered in Kent County, we had a very short period of time to figure out how to get 295 employees working from home. So we had all of our staff on site basically every day. Network 180 is open 24 hours a day, 7 days a week. Our access center is to serve anybody who walks in. And we knew we needed to keep that function open. It was very important that for the safety of the community, that access center remain open 24/7, but be able to do that in a safe way. So it was no small feat to try to figure out how to get all of these individuals working from home. And when I talk about our employees, we have some employees who are kind of on the back end, they're doing finance, they're doing billing. In that sense, that was a little bit easier, but we have a lot of employees who are actually doing direct service with the individuals we serve. And we couldn't have all of them in the building. So we needed to figure out how are we going to get them home and how are they going to be able to do this work from home. IT equipment was key here. We had some staff, taking monitors from the office, taking them home. We're fortunate that staff already had individual tablets that we provide them. So that was a good jumping off point. But there were other IT needs that they needed at home, including for some people, upping their internet capability to be able to work from home. So our IT department was extremely busy during this time. PPE, as you may remember, was really, really hard to come by in the beginning. So in those first weeks, Dr. Achtyes and I were on calls every single morning. And I remember the questions every morning were, who is going to get the PPE? And to have to sit there every morning and try to decide which staff are going to get an N95 mask and which staff might get a cloth mask is really, really difficult. Luckily, we are in a much better spot now and we have the PPE that we need, but in the beginning, we absolutely did not. We had to make some building modifications. So we had two sites. One site that primarily sees the people that we serve. We have 3 different clinics at that site on multiple floors, and we really wanted to reduce the amount of traffic in the building. So remember, this was very early on. We still didn't know much about how this virus was spreading. Could it, you touch a surface and get it? There was, lots of theories out there. So we wanted to minimize the traffic through the building so that we could have better cleaning protocols and better infection control protocols. So we actually, we had a clinic on our 4th floor, which, we do a lot of antipsychotic injectables on that floor. So, multiple people coming in per month to get their injections. And we actually had to transform, we had to rebuild a restroom that was on our 1st floor in that 24/7 access center so that we could turn it into an injection room. And that was all to just minimize the traffic that was going through the building. As Dr. Achtyes mentioned, we had coding and billing changes. So the state said, okay, you can do telehealth now for these services. We'll allow that. And we'll also allow you to even do phone calls and do some billing for phone calls. Our electronic health record and most others weren't set up to do that. So there was some rapid transitioning that had to happen in order to make sure that we could code and bill those visits correctly. And as you can imagine, we had to adjust policies and procedures, and we're still continually doing that. As new information comes out from the CDC, we are revising our policies and procedures for staff and for our interactions with clients on a weekly basis. The other thing we did is we started an infection control work group. That infection control work group is still meeting every other week, more often as needed, to again look at everything that we're doing, make sure that we've got the most up-to-date research, that staff are aware of what the protocols are and how they're changing according to CDC and state guidelines. And so I do not see that going away anytime soon. So we obviously have implemented screening processes as well, not only for consumers coming in to the building, consumers of services, but also for staff coming in, which we continue to refine.
So Kristen talked a lot about this, but this chart summarizes how service delivery changed abruptly and rapidly at Network 180 due to the pandemic. So I realize this is a little bit hard to see this legend here, but the yellow are office visits. So this is 2019. This is what we would normally do in the office. We had some visits that are out in the community. So those were, some of these pink visits. Orange was telehealth, so we were doing some telehealth even prior to the pandemic. And then this purple are visits in the home. So we do a fair bit of our work visiting people in their homes. And you can see here's March, and this blue and this darker blue represented here represent the change in COVID-related telehealth visits. So our percentage wise of telehealth visits jumped from about 5% of all the services we were providing prior to the pandemic to 84% of the services we were providing as we transitioned from March to April to May of last year. You can see down here the number of visits per month. So this is how many visits we were doing. We had a little dip in March when things shut down, but then early April, but then things have started to pick back up, and we don't show the through the fall, but we've gotten very busy and we've stayed very busy going forward. So we were actually able to publish this work in a journal, Primary Care Companion for CNS. Now, the majority of the services we provided were audio only. And as technology became more available for people, again, some of the consumers we serve don't have, broadband in their homes or have a way to do an audio-visual link. But over time, that component has bigger and bigger. And we do think there are some advantages to being able to do an audio-visual visit as opposed to just a telephone-only visit. Okay, so we transitioned our services very, very quickly. Well, what did the people we were serving think about that? Did they like telehealth? Did they like the flexibility? How did it work for them? So this was a study that was published in this past year in 2020 on patient attitudes towards telepsychiatry during the COVID-19 pandemic. And it was a nationwide survey that some of our colleagues in New York did, but we actually participated in it here in Grand Rapids as well. So we surveyed a number of the individuals we serve over at Cherry Health in downtown Grand Rapids. And this particular publication looks at telemental health, so telepsychiatry and its related teletherapy. How did people find that service? So in total, there were a little over 3,000 individuals who were surveyed, who participated in this. And overall, they liked having the ability to do telepsychiatry, either audiovisual or telephone only. 82% rated it as excellent or good. 64% found them to be helpful, found the visits to be just as helpful as in person. They liked the lack of commute. So 46% said that was a positive. They liked the flexible scheduling. That was also a positive. The things that they missed were going to the clinic or the hospital where they were used to receiving care. So there is something about that familiarity of coming into a building, seeing people that you know, that is comforting for a lot of people. And so that was something that was missing. And then 25% said they didn't feel as connected to their treaters as they do when they're in the office with them. Overall, though, 64%, so almost 2/3, felt like they would like to continue some level of telepsych or teletherapy going forward.
So this is what we found internally. As I was saying before, we provide services to a wide variety of individuals with different chronic conditions. And there are some pros, as Dr. Achtyes was mentioning, to telehealth. So we serve a number of individuals who have transportation barriers. That's always been something that we are trying to work with people on and get resources for. So with telehealth, they weren't having those transportation barriers, so they could stay in their place of residence and engage with their physician or their therapist right over the telephone or over a screen. So patients said it was convenient, that they thought that, not having to travel sometimes on multiple bus lines to get to us was really helpful. It was also incredibly convenient for adult foster care homes. So adult foster care homes, they may have 6 to 12 individuals living in those homes. Sometimes those individuals have a mental illness. Sometimes those individuals have an intellectual developmental disability. And in the past, if one of the individuals had an appointment with a provider, the manager would have to load everybody up in the van and take everybody to the appointment because the individuals can't be left alone in the home. So this was really convenient for some of those AFC homes. We saw some improved attendance, so people were more likely to keep their appointments. And we think that's partially due to the lack of transportation barriers. And we also saw that there were shorter, more frequent sessions. And we found that this was especially helpful for the individuals we were serving with psychotic disorders. That versus that appointment where they come in and they meet with somebody for your traditional 50-minute therapy session, that these shorter but more frequent sessions were actually far more effective. So that was something that we learned through the process. We also saw there was increased access to recovery meetings. So for individuals who were struggling with substance use disorders or who are in recovery, they could access smart recovery meetings on the web anywhere in the world, any time of day or night. And that wasn't possible before. So this has been a huge benefit to that population. And even to our staff. So if you're in this field and you need therapy yourself, sometimes it's difficult to go to somebody who probably knows you through some other workplace, because we're all so connected in this field. Now you can link with a therapist across the state. You can link with a therapist in another state. So that's offered a little bit of anonymity for people who may have been hesitant about receiving therapy in the past. Cons, the number one con for all populations is technology barriers. As Dr. Achtyes mentioned, some of our individuals we serve don't have any access to technology. They don't have access to any internet. So we had to come up with a variety of solutions for that. One of the things that we did is We had some parent support partners who are individuals who have lived experience with a child with a severe emotional disturbance who work for us, and they provide support to other parents. And they actually volunteered and said, hey, we will help get people set up with technology. So they were in the office and they were on the phone with people, with AFC Homes, with whoever it was, actively talking them through, how do you get into this appointment? How do you work the technology? We also opened up some of our rooms in our access center and made them telehealth capable. So if we had somebody who didn't have access to telehealth, they could come into the access center and do their telehealth therapy appointment right there. The lack of privacy has been a concern, especially for individuals who have multiple people living in their home environment. You know, there's a sense that they can't be, individuals receiving therapy especially, or psychiatry, can't be as open as maybe they could be if they knew they were alone in a room. This has been especially true for the adolescent population. This fear of kind of speaking their truth when somebody else might be able to hear them. Some modalities just are not feasible through telehealth. So there's some evidence-based therapies like applied behavioral analysis for autism, or eye movement desensitization reprocessing, or EMDR, which is for trauma. And some of those modalities for therapy just do not work over a telehealth environment. There's limited ability to read affect and body language, especially with those phone visits. We are trying to move away from those telephone only visits, and that's the way the state is moving as well, because you just can't get the whole sense of what's going on with somebody when you can't read their body language. There's been some difficulty building rapport because that's been more difficult for some folks over a screen. The lack of vitals. So if individuals were receiving their psychiatry appointment and they were at home, we weren't able to get an accurate weight, blood pressure, you know, other vital signs on them prior to seeing the psychiatrist. And so that's been a barrier. Multiple interruptions during sessions. Again, other family members, kids running through the room. I know any of us who've been on a Zoom call have experienced some of that, but when you're in a therapy session and having those interruptions, that's been difficult. Ability to get forms and signatures on key documentation that we need. And then this inability to see the home environment. So, you know, that gives you a lot of information as to what's going on with an individual. Is to be able to see the home environment. And we do rely a lot on home visits for some of the populations we serve. And then, as I was saying earlier, some interventions just cannot be done via telehealth. Next slide, please. So a few population specifics are individuals who are experiencing homelessness, obviously don't have access to telehealth. And so that has been a population that has been harder to reach out to. We've been trying to do some innovative things there to reach out to that population. Those who are experiencing domestic violence, this is part of the privacy of being able to come in to a facility or an agency and meet with your provider face-to-face versus having to do that telephonically when somebody else in the room might be able to hear you. So that has been a struggle. Children and adolescents has been one of our hardest populations to engage with over telehealth. It's hard to do play therapy. It's hard to, you know, break out the crayons and have kids draw things and do those type of interventions over telehealth. Those with intellectual and developmental disabilities, some of our population is nonverbal, and so they have had some difficulty adjusting to telehealth. And then those who are isolated. So, you know, one of the treatments, you know, part of the treatment for somebody who is experiencing severe depression is we might say, you know, hey, like you're gonna come to see me at the agency, you know, on this day next week. And that may be the only time that they actually get out of bed and get dressed and get moving. And that is so important. And so when we're just doing telehealth, there's not that same level, and people have felt really, really isolated.
So some of our colleagues at Pine Rest were also very interested and very worried about what would be happening to people's mental health as the pandemic came on and then persisted. And they actually published a very nice summary of concerns that may be associated with the pandemic. And they specifically looked at mental health in Michigan, which I thought was really excellent. And they compared the current pandemic to previous deadly infections like SARS or other economic recessions to give us clues about what we might, need to worry about as the pandemic continued. And these were the lessons that were learned from other previous pandemics or financial crises. So with financial loss, you have increased risk for suicide. So in previous recessions, suicide rates have increased 1.3% for every 1% increase in the unemployment rate. So if we look at Michigan specifically, the unemployment rate rose from a rate of 3.6%, very, very low in February of 2020, to 21.7% by the end of April 2020. So that would translate into about a 24% increase in suicide rates in Michigan by the end of the year, if that persisted. Kristen talked a little bit about social isolation and quarantine, and we think about the elderly populations here too, who may be isolated already. We've heard a lot in the national news about people in nursing homes and how they can't visit family, they can't in the same ways, and that is incredibly challenging for people who may already be socially isolated. The closure of schools, businesses, places of worship, of course, loss of business has an implication for financial loss for many people. Closure of schools has a huge impact on kids and their learning. And then in addition, that links into domestic violence. So kids who are forced to learn at home in unsafe situations, the risk for domestic violence also increased. We've also heard about how the reduction in sporting activities and hobbies have affected some, especially young people. We've seen an increase in gun sales, an increase in substance use disorders. So that's happened as well. And tremendous stress for frontline workers. I mean, we think about, people in the food industry, people in grocery stores, people in hospitals who were working at the very beginning of the pandemic when PPE was limited and we still didn't really know how this virus was transmitted. And again, Kristen mentioned, the question of whether it could really be transmitted easily over surfaces. So there was tremendous stress for frontline workers. And then we have the tremendous loss of life. So as you know, we're over the 500,000 mark in terms of deaths due to COVID-19, specifically in the United States alone in the past year. And overall, in the United States, COVID-19 is now was the third leading cause of death in 2020 for all Americans. So it is, rocketed right up to the top in terms of direct cause of death. Talked about domestic violence, insomnia, inflammation. So COVID-19 is a tremendously inflammatory disease. You get all sorts of inflammation in the lungs and upper airway, and we think that can lead to depression as well. Now, this graph that they published in this article shows, it's a little bit hard to see, but the green line are the 2018 deaths by month in Michigan. The blue triangles are 2019 deaths by month in Michigan. And then in 2020, we have the orange line are non-COVID-19 deaths. So we even saw a little bit of a spike there in deaths unrelated to COVID-19. And that could be indicative of people being afraid to go in and get healthcare that they would normally otherwise get. And then quite a large spike in the month of April, which are 2020 deaths in total. So that includes the COVID-19 deaths. Now, the recommendations from this report were to do things like increasing our investment in telehealth, waiving copays so that people could get in to get care. They advised shoring up the behavioral health workforce and continuing to invest in mental health infrastructure.
So this slide just illustrates a little bit about what Dr. Achtyes was just talking about. So these are Kent County enrollment trends for those who are enrolling with Medicaid. So the kind of this orange number here, this line at the bottom, that bottom line represents people who are on Medicaid because they're disabled, aged, or blind. That's what DAB stands for. And you can see that that hasn't changed much, the enrollment on Medicaid based on disability. What is changing is Healthy Michigan Plan. So Healthy Michigan Plan was the Medicaid expansion that Michigan put in place after the Affordable Care Act was passed. So you can see the numbers on the left-hand side of your screen for October of 19 and how this trend continues to go up for Kent County. And we think that that is a direct reflection on those who have lost jobs and businesses. So it just illustrates again the effect that this pandemic is having and then can have on people's mental health.
Now, I just wanted to say a little bit too. So this is being superimposed, the pandemic is being superimposed on a backdrop of increasing suicide rates in the United States. So this is data from the CDC's National Vital Statistics Program going from 1999 to 2016. And across the country, we had seen increases in suicide rates. So the darkest blue is the worst, an increase from 38 to 58% over that time period. The slightly less dark blue is next. And Michigan, if you look, was in that category. So from 1999 to 2016, our suicide rates in Michigan had increased by 33%. So that made us worried, what was going to happen with suicide rates as the pandemic took hold. This is just another way to look at some of this data. So this is, again, from the CDC, looking at leading causes of death by age group. So this is from 2005. And you can see that suicide, the green boxes, were the #2 cause of death for people aged 25 to 34 back in 2005. If you fast forward to 2016, suicide was now the second leading cause of death from ages 10 to 34. So again, a worsening trend. And then in some of these other age groups, suicide had also moved up. So in the 45 to 54 age group, it had moved up. And it had also now appeared as the #10 cause of death nationwide. So again, we were pretty concerned as the pandemic continued. So what have we seen in Kent County? So this is Kent County specific data from the year 2019. And in 2019, we had a total of 87 deaths due to suicide. The age groups are disproportionately young. So 30% of those total deaths were in the age range of 18 to 29. So that's very concerning. Overall, ways that people died were the top 3 were by use of gun or hanging or overdose. Among women, the most common method of loss of life was drug overdose during that time period, followed by hanging. And in men, it was gun, followed by hanging. And this is pretty common. You'll see that it was about 3 to 1. More men dying by suicide than women over that time period. When we look at the 2020 statistics, again, we were very nervous. And these are not final statistics, but it is from January 1 through December 31. We were relieved to see that we had a lower number, 61 confirmed deaths by suicide with 6 more pending. So it's possible that this number could get as high as 67 for 2020. And again, the trends were disproportionately for people of younger age. So 18 to 39 were the 2 most common age groups. Again, gun was the most common means, followed by hanging and then drug overdose. In females, hanging was the #1 method. In males, it continued to be gun. And in 2020, it was about a 2 to 1 ratio of men to women. As far as 2021 goes, this is data from January 1 through March 3rd. So really only about 2 months worth of data. And we had 16 deaths by suicide. Now, if that trend were to continue and you multiply that by 6, we're looking at being back up in the 90s in terms of deaths by suicide. Now, There is some seasonal variation. So, typically if we look back, often the summer months have lower numbers of death by suicide. So it's possible that this rate will slow down during certain months, and we certainly hope that's the case. But that gives you a little bit of a sense for how we're doing so far in 2021. This just summarizes Kent County statistics over the last 10 years or so. So 2011, and these are raw numbers. So these are total numbers of death by suicide. It's not a population weighted factor. So 63 back in 2011. And again, like the national statistics, we saw this slow, steady increase over time. 2018, we had 97 deaths by suicide. In 2019, it dropped to 87. And then in 2020, we would have a maximum of 67. Now, this also mirrors national data. So nationally, there was a slight decline in overall rates from 2018 to 2019. So the CDC reported that it was a statistically significant decrease from 14.2 deaths per 100,000 people to 13.9 deaths per 100,000 people, or a total of 833 fewer suicides in the US in 2019 than in 2018. Now, another alarming trend that we've seen beginning in 2013 and progressing through 2019 is that rates of suicide for Black youth and Asian and Pacific Islander youth have been increasing. So among Black boys and young men aged 15 to 24, the suicide rate increased by 49% from 11.5 per 100,000 in 2013 to 17.1 per 100,000 in 2019. And for Asian, Pacific, and Pacific Islander boys and young men aged 15 to 24, the rate increased by 39% from 11.9 per 100,000 to 16.6 per 100,000. Similarly, in Black girls and young women from 2013 to 2019, we saw a 62% increase in deaths by suicide among those aged 15 to 24, from 2.6 per 100,000 to 4.2 per 100,000, and a 47% increase among Asian Pacific Islander girls and young women from 3.6 per 100,000 to 5.3 per 100,000. So even though we're seeing some hopeful trends nationally, there are subgroups where we've actually seen increases in suicide rates over the same time period. Okay, so I wanted to transition to talk a little bit about how does COVID impact the people that we serve. So there are a couple of studies here, and I'll walk you through them. The first was a large study done in South Korea. And they did a nationwide study there. I think many of you may remember in the news, South Korea was one of the nations that did a really good job of testing and contact tracing very early on in the COVID-19 pandemic. So they did routine testing and they really traced people very, very carefully. And what they found is that if you have a severe mental illness versus not having any sort of mental illness at all, and you look at people with any mental illness, other mental illnesses, there really was no difference in terms of who tested positive for COVID-19. So whether you had a mental illness or not, it didn't affect your risk of getting the virus. I mean, and that makes sense, right? Like we're all hopefully being out in the community and being careful. And the same was true for those with mental illness. They were being careful as well. And we didn't see increased transmission rates in that population. However, when we look at severe clinical outcomes, so these were defined in this study as ICU admission, need for ventilation or ventilator use, or death, there was an increase for those with severe mental illness. So they had a 2.27 times the risk of people with no mental illness for having a severe outcome. And that was robust. And it didn't apply to some other mental illnesses. So if we think of, anxiety disorders, or we think about depression, that didn't apply for those groups. They did not have an increased risk in the same way that those with severe mental illness. And the way they defined severe mental illness in this study was essentially having a psychotic disorder. So the second study that was also important was one conducted here in the United States. They looked at 7,348 COVID positive patients in New York, and they looked at 45-day mortality, so who had passed away by day 45. And then they looked at diagnoses that might be important for that. So they looked at a whole host of things that would put you at risk for a worsened outcome with COVID, things like high blood pressure, diabetes, being a smoker, chronic kidney disease, cancers, having had a heart attack, chronic lung disease, so chronic obstructive pulmonary disease. And then they also put in there age, which of course we know is an important risk factor. And they put in different classes of psychiatric disorders. So they did psychotic disorders, they did mood disorders and anxiety disorders. And what they found in this analysis was that having a schizophrenia spectrum diagnosis gave you, again, a 2.67 times risk of having a worse outcome, in fact, death due to COVID-19. And that was really on this list, second only to the risk factors associated with age. So you can see the risk if you were in the 45 to 54-year-old category, 55 to 64, 65 to 74, and greater than 75, you had the highest risk compared to others. But in terms of other conditions that put you at risk, schizophrenia and psychotic disorders was right at the top. Okay, so how else did COVID-19 affect people? So this was a survey study done of 4,294 Canadian adults from April 3rd to June 23 of 2020. And what they looked at was screening for new cases of depression, generalized anxiety, or substance use disorder. And what they found was that there was a 29% increase for new cases of depression during that time period, a 12% increase in generalized anxiety disorder, and a 15 to 19% increase in the use of alcohol or cannabis during the early days of the pandemic. So a little bit of good news. There have been a couple of studies now, important studies that have shown that antidepressants may have some protective risk of preventing people from developing severe COVID-19 disease. So the first study was an observational study of more than 7,000 adults who were hospitalized for COVID-19 in 39 Paris area hospitals. So this study was done in France. And they looked back at people who had received an antidepressant, 345 of them, within 48 hours of hospital admission. And what they found in this study was that they had a 44% reduced risk of intubation or death if they were on an antidepressant when they were hospitalized. So this is a survival curve, a Kaplan-Meier survival curve. And if 100% of people stayed alive, the line would go straight right across the top. And what we see is this blue line, these are people who are on an antidepressant, and their survival was 44% better than individuals who were not on an antidepressant and who were hospitalized for COVID-19. And then, so this can just look at associations. It can't prove causality, but we can say that antidepressant use was associated with a lower risk of intubation or death. This group at Washington University in Seattle then did a prospective study of 152 outpatients and randomized them to receive an antidepressant, fluvoxamine, 100 milligrams 3 times a day, or placebo 3 times a day for 15 days. So just a short course of this. And then they followed people to see whether they had, again, a severe outcome. What they found in this study was that individuals who had clinical deterioration on the fluvoxamine group, none of the 80 people who were on fluvoxamine had a clinical deterioration, while 6 of the people who were randomized to placebo did. So this was an absolute difference of 8.7%. And you can see here, so the survival curve, this blue line at the top, these are the people who received fluvoxamine, the antidepressant, and the people who were randomized to receive placebo, there were more clinical deterioration. And because this was a prospective randomized study, you can attribute causality here for the antidepressant in terms of potentially having an effect on on the outcomes. And I would just caution people, I mean, we need much larger double-blind randomized trials, to assess the actual benefits of antidepressants for people with confirmed COVID-19. But this is some helpful hints that it may have a positive effect. Okay, and then I did want to touch base again a little bit on the emotional impacts of COVID-19. So this is a slide that SAMHSA has put out on their website. It's about recovering from disasters. So this was actually on their website prior to COVID-19. You could go and look for it prior to this, and it applies to all sorts of disasters. But there's kind of a common series of phases that we all go through as we're dealing with something big, bad, and terrible like a pandemic. So there's this pre-disaster phase. There may be a warning of a threat coming, and then it actually hits, and there's this impact. And we feel it. We're all scared. We're nervous. And then we enter this kind of heroic phase where, I remember last spring we were thanking everybody for their service. There was a lot of outpouring of appreciation for nurses and other healthcare professionals that were on the front lines and dealing with this in some really pretty horrible situations without sufficient PPE, without any sort of other protection. And then there's kind of a honeymoon phase where you're kind of in that good feeling period for a little while. And then as it drags on, you begin to feel some disillusionment, like, when is this ever going to end? When are things going to get back to normal? When are our kids going to go back to school? When can we visit grandma and grandpa again? When is my business going to be able to open again? All of these things feed into this disillusionment. There's all sorts of, we may feel upset about, policies that are being made that we don't agree with or we don't like. And then eventually, hopefully we can begin this reconstruction phase where there's a new beginning. And I think for many of us, vaccines are bringing a hope that we can begin and continue this reconstruction phase, that we can begin to open things back up and return to more of a pre-pandemic existence.
Okay, so we wanted to talk just a little bit for the next couple of minutes here about effects on children. So the Michigan Department of Health and Human Services, the Community Mental Health Association of Michigan, and the Michigan Department of Education just recently released a paper on child and adolescent mental health as a result of COVID. Really looking at this from a Michigan perspective. Next slide, please. So they referenced several different studies here. And what they did is they surveyed parents and youth, and they looked at the period of April 2019 to October 2019. And then they did a comparison from that period to April 2020 to October 2020. So April 2020, just the pandemic had just kind of hit. Kids had been home from school for a couple weeks, and then ran that through October. So they compared the two. So with Michigan households with children, 34% report children feeling nervous, anxious, or on edge as compared to the period the last time or the previous year. And 22% report children feeling down, depressed, or hopeless. So that obviously there's a variety of reasons for that. There's fear about catching COVID. There's fear about losing a loved one to COVID. Children who are out of school and now no longer have that interaction day to day that they rely on, especially those who are receiving special education services. As Dr. Achtyes mentioned previously, that can lead to more domestic violence. And for some of these kiddos, the school interaction and interactions with primary care physicians was really their safety net for catching what might be going on emotionally with them. And so what essentially happened is that they were out of school and they were at home with family the entire time, which is a stressful period for everybody with everything that's going on. And then they also were not typically going in to see primary care physicians because people were delaying care, especially care that was just routine because of the pandemic. And that's where a lot of times things get picked up on for kids in terms of mood disorders or, even suicidal ideation. And so we removed those protective factors. So that had a big impact. In terms of mental health related emergency room visits, so these are kids that went to the emergency room, typically that's DeVos, and it's for a mental health reason. So there was a 24% increase in children ages 5 to 11 and a 31% increase in children ages 12 to 17. Again, you imagine, especially children who are already predisposed or have some sort of mental illness or anxiety disorder or depression, and then you add in a pandemic and being stuck at home with family and little interaction with others, and that has increased the traffic to emergency departments considerably. One of the things that we've been working with DeVos Children's Hospital on is that there really was no inpatient psychiatric unit for COVID positive children. So if a child was suicidal or thinking of harming somebody else and they needed inpatient psychiatric treatment, there was not a facility that could take them if they were COVID positive. So they would just stay at DeVos Children's Hospital, which really isn't getting the targeted psychiatric care that they need. Next slide, please. So then they looked at emotional well-being of children since the onset of the pandemic, and parents are saying that 72% of parents witnessed a decline in their children's emotional well-being. And that's for all the reasons that we've been talking about: that isolation, fear of contagion, lots of political and racial unrest going on, and the economic insecurity. So you can imagine children dealing with a parent who's lost a job and potentially then losing a home. And then the COVID mental health impact of 41% of those surveys reported an adverse mental or behavioral health condition related to COVID-19. So whereas the previous numbers, 72% is a decline in emotional well-being, 41% is actually attributed to a child or adolescent who actually now appears to have a mental or behavioral health diagnosis or condition as a direct result of the COVID-19 pandemic. They also, in the survey, they asked 18 to 24-year-olds about, thoughts of suicide, and 25% of 18 to 24-year-olds reported considering suicide in the month before the survey was taken. That's a dramatic number, 1/4 of them in that population, and it fits with the stats that Dr. Achtyes was sharing earlier regarding the increased deaths by suicide in that population. So although this isn't real positive news to end on, it's just to say that I think we are only now starting to experience the mental health effects of this pandemic, and these mental health effects and the trauma that people have ensued will have some long-lasting impacts that we need to be aware of.
And we're happy to take questions if there are any.
Yeah, happy to open it up to questions that anyone has, and feel free to use the raise hand feature, and I'll go ahead and call on you if you've got questions. While we wait for anyone that has questions, I just really wanted to extend a sincere thank you. I mean, especially for those on the call that are going into healthcare or public health or whatever role that they might have. I think recognizing kind of the impact that COVID had on mental health, and especially for youth, is crucial, because many of these students are close to entering into clinical settings in various capacities. So really, really relevant and timely information. So really thank you for that. Any questions that anyone has? So we'll give a 30-second pause here maybe for questions.
And while we're seeing if there's any questions coming in, Brian, I'd highlight that, Kristen mentioned, and you mentioned it as well, that as we're getting through kind of the acute phases of COVID-19, and we're learning how to better treat the COVID-19 illness, but then also hopefully prevent further transmission of the virus, the mental health impacts cast a much longer shadow. And the impacts will be felt for, well beyond the acute phases of the COVID-19 pandemic. So I think that's really important for people to understand and to appreciate that. Even if we were able to attain herd immunity and really reduce transmission of the virus, the mental health aspects are going to be continuing for a long time. And I think that's important to understand.
Thank you. Just wait
I have a question. I wasn't
Sure.
able to raise my hand. First of all, thank you so much for the presentation. It was really interesting, and it was interesting to hear all those stats. My question for you is, for your organization, do you think that telehealth is something that you guys will continue to create infrastructure for and build upon? Or is telehealth seen as kind of like a short-term solution for what's going on right now?
Kristen, do you want to go first, or?
Sure, that's a really good question. And we've talked about this a lot as an organization. So as I mentioned, there's pros and cons to telehealth. So we do want to be able to maintain some sort of telehealth capability. Especially for individuals who, have transportation barriers, as we talked about, or, maybe they're just not feeling well on a day. We don't want them coming to the office, especially now. We want them to be able to engage with their provider without having to come in. However, we also know that it's not the standard of care that we want for everybody in every situation. It is important to get that face-to-face interaction. So I think we will be transitioning back to mostly face-to-face interaction, kind of as the default. But the idea is to keep some of the telehealth interaction to be used when we need it and when it's appropriate.
Yeah, and I mean, nobody knows exactly what that right balance will be. We changed from 4%, 5% of our services being telehealth to 84% of our services being telehealth. What's that right ratio? I don't think we know right now. I can imagine, maybe we'll get back, we'll flip back to maybe 60 or 70% in the office, and maybe it's, 30% via telehealth. I don't know what that number is going to look like. Part of it has to deal with whether the changes in the law that were put into place around extending telehealth coverage and mandating that insurers pay for that, if that will continue. And if it does continue, then I think it opens up opportunities for us to continue to provide that service. If the payers of the world, Medicare, Medicaid, say, no, you can't do telehealth anymore, or we're only going to pay you half as much for a telehealth visit, I think you're going to see that providers switch pretty quickly back to requiring inpatient visits, because they won't be able to survive if they're not paid at a similar level. And then the other thing that I would just, and Kristen highlighted this too, that I think was a major advantage of being able to offer telehealth, is for those with barriers, with real legitimate barriers, the no-show rates went down pretty significantly. I think in the clinics in which I work, they were cut in half, basically. So rather than having somebody not show up for an appointment, half of those people were showing up because we could reach them via telephone or via televideo. And I think that is really an important gain that we're going to want to be able to hang on to going forward.
Particularly for those that look like there was a statistic about those in groups for substance abuse or disorders that were able to maintain access, regular access to some of those groups, maybe whether in the future people are traveling or have a health issue on their own. So that looked like an important piece learned from all of this too. Any other final questions from anyone before we wrap up with our guests? I also wanted to mention that chart that you showed. That was the first time I've seen a chart like that, that one that kind of showed the heroic, and then the kind of disillusionment stage. I think that was really interesting, and probably also important, I think, for students to just maybe remember this going forward, whether it's another pandemic or other issue, or maybe even something personal that happens, that sometimes there's these stages to how these things go. And I thought that was just a fascinating piece, not only related to mental health, but just our own journey through some of these other things that we might face. So I just want to again thank both of our presenters, both Kristen and Dr. Achtyes. Again, it was an excellent presentation, and thank you to all the students who and staff and faculty and community members that attended. We have one more Lunch and Learn coming up in April. But again, thank you to our presenters for today, and we hope that you have a great rest of the day.
Thank you, Brian. We really appreciate the invitation and appreciate everybody tuning in.
Yes, thank you.
Thank you.
Thank you so much.